Assalamu alaikum. I am Dr. Gazi Zakir Hossain, Associate Professor Surgery, Bashundhara Ad-din Medical College. I welcome you all in our surgical class, all students of final year MBBS. Today, our topic is gallstone and gallstone diseases. All of you know that gallstones are of three types: cholesterol stone, pigment stone, and mixed stone. Among them, mixed stone is more common, about 75%. Now, the presentation of gallstone. Gallstone is a disease of female, and above the age of 40, 10% of the female of the population suffering from the gallstone disease. Genetic predisposition can also causation of the gallstone. Gallstone is common in female, fat, fertile, and after 40. Now, pathogenesis of gallstone formation. Before that, we have to know the composition of the bile. Bile, about 97% bile percentage of the composition of bile is water. Remainder is bilirubin, cholesterol, bile salt, lecithin, and inorganic salt. Bilirubin comes from hemoglobin. Cholesterol kept in solution by the detergent action of bile and lecithin. All of you know that bile salt are of four types: cholic acid, chenodeoxycholic acid, deoxycholic acid, and lithocholic acid. Lecithin increase the solubility of the cholesterol. Before causation of bile stone formation, you have to know the function of the gallbladder. All of you know that gallstone have three functions: reservoir of bile, absorption of bile, but that is the concentration of bile, and secretion of mucus. Now, the pathogenesis of gallstone formation. Cholesterol stone formed due to imbalance of bile salt and lecithin and cholesterol. Then, cholesterol dissipated and causes formation of the bile. That is also known as it is formed in supersaturated bile. Now, the pathogenesis of pigment stone formation. Due to excessive circulating bile pigment in the blood, cholesterol in the bile, pigment stones form. It is due to hemolysis of the hemoglobin. Mixed stone form as well as the cholesterol stone. Other factors responsible for bile stone formation is the stasis, which occurs in pregnancy. Ileal dysfunction is also another factor which prevents reabsorption of bile. Obesity and hypercholesterolemia is also responsible for bile stone formation. Factors associated with gallstone formation are impaired gallbladder function, supersaturation of bile, cholesterol nucleating factor, and impaired absorption, that is impairment of the enterohepatic circulation. Now, how gallstone presents? What is the complication of gallstone? Nearly 80% of the gallstone is asymptomatic. 20% may develop complication, which may occur single or recurrent basis. What are the complications of gallstone? These can be summarized as gallstone, that is the biliary colic, acute cholecystitis, which may lead to empyema of gallbladder, gangrene of the gallbladder, perforation of the gallbladder, and mucocele of the gallbladder. Gallstone may pass through the cystic duct into the bile duct, may cause obstructive jaundice, may cause ascending cholangitis, pancreatitis, gallstone ileus, though it is rare. To summarize, the complications of the gallstone are biliary colic, acute calculous cholecystitis, obstructive jaundice, ascending cholangitis, pancreatitis, and gallstone ileus. What are the differential diagnosis? Differential diagnosis is gallstone disease, is gastritis, duodenitis, peptic ulcer disease, that is the perforation of the peptic ulcer, acute pancreatitis, right lobar pneumonia, myocardial infarction. If patient present in the accident and emergency department due to right upper abdominal pain, we must do blood test, that is the complete blood picture, liver function test, X-ray of the chest and ECG to exclude the differential diagnosis. To differentiate the complication of gallstone disease, we have to take history and clinical examination of the patient and blood test. Blood test among the blood tests, we have to full blood count, liver function test, clotting factor, serum amylase. Complication can be distinguished by the above methods. For the diagnosis of gallstone disease, we have to investigate the patient. Among them, blood examination have said previously, we have to do X-ray abdomen, 10% of the gallstone is radiopaque, X-ray chest to exclude the perforation, ECG to exclude myocardial infarction. Then we have to do ultrasonography of the whole abdomen. It is the first line investigation for the diagnosis of gallstone disease. It confirms the presence of gallstone, and wall thickness can be measured through the ultrasonography, biliary caliber, common bile duct caliber, extrahepatic and intrahepatic biliary, whether it is dilated or not, and sometimes CBD stone can also be diagnosed at the same time. We can prescribe for diagnosis the MRCP, magnetic resonance cholangiopancreatography for the diagnosis, and ERCP for the special cases to diagnose the gallstone diseases. If there is any features of cholangitis and jaundice, we can do PTC, that is percutaneous cholangiography. CT scan can be done in limited cases where there is perforation, gangrene, empyema of the gallbladder is suspected. Now, gallstone may cause biliary colic. A stone intermittently obstructed the cystic duct, causing pain. When it drops back into the gallbladder, pain subsided. Ultrasonography confirms the presence of gallstone. Treatment is conservative, analgesic, fluid resuscitation. If pain, give analgesic diet. Now, what is the pathology of acute cholecystitis? It is due to obstruction of the cystic duct by the gallstone. Cystic duct blockage by the gallstone, obstruction of the passage of bile from the gallbladder, bile become concentrated, chemical inflammation occurs initially, secondary it is infected by the organism released by the liver into the bile stream. Ultrasonography can confirm the diagnosis, presence of gallstone, thickness of the gallbladder wall, pericholecystic collection of the fluid can be diagnosed, can be identified by the ultrasonography. What is the complication of cholecystitis? It may lead to empyema gallbladder, gangrene of the gallbladder, and perforation of the gallbladder, though these are rare. Occasionally, a stone may remain in the region of the cystic duct or in the Hartmann pouch, may cause mucocele of the gallbladder. What is the treatment? Treatment is admission of the patient and monitoring the vital sign, fluid resuscitation, analgesic, intravenous antibiotics, and maximum patient response to the conservative management. Later on, if the patient presents within the 48 hours of presentation, then we can suggest him for operative treatment. If patient presents late, then we suggest conservative treatment and later admission after 3 to 6 weeks for the elective cholecystectomy. I thank you all to participate in our class.